different targeted therapies have different modes of blocking pathways.
Mm-hmm.
Do any of these agents, would that have any impact, or has your research shown any impact on different pathways?
Okay, it's a very good question, and not a simple one to answer. Many of the treatments I talked about, the cytokines like IL-2 and interferon and CTLA-4, work on the patient's immune system, we think, only. Meaning they're boosting the immune response to an established cancer, and for reasons we don't completely understand, that response is effective in some patients and not others. In the case of the PD-1 antibodies, they may be acting on the immune system, but they also may be acting on the tumor as well. And there's some evidence of that in very early research, which suggests that patients who, as I mentioned, have this barbed wire on their surface of their tumor, so have this pathway activated, to use your term, when the pathway is on, they may be more likely to respond to this approach. Meaning when the barbed wire is up, if you can block its activity, maybe you can then lead to an effective immune response. And what that may say something about the importance of the pathway, but it also may say something about the immune system's response. Meaning the barbed wire, we think, is up as a reaction, as a survival mechanism for some tumors. I mean, it's one of the reasons cancer is so difficult to deal with, is there's so many different ways a tumor can evade the therapies we have. And this barbed wire, this PD-1, PD-L1 pathway, may be one of those sort of protection mechanisms. Now, so that means the tumor, it turns on, barbed wire shows up when the immune system is there, can't kill it, but you can block the barbed wire, then you can take these immune cells that are right there and kill the cancer. That may explain why some patients benefit from this treatment and some don't. And we're now looking at whether if your tumor has barbed wire, whether you're more likely to respond to treatment. There'll be a lot more information about that in the future.
Great, thanks, Dr.
Good question, though.
I was wondering if you knew of a clinical trial that's going on for it's prostate cancer, I think it's called X184, and if it's for bone mets, and I was wondering if you knew anything about its, work with RCC.
Oh, okay. You brought the question around to something I could answer, which is good. Yeah, no, I don't treat prostate cancer, just melanoma and kidney cancer, but I think the drug you're talking about, is it XL184? Yes, okay. So XL184 is a drug that's in early development. And maybe Dr. Yonash after lunch may talk about similar drugs. These drugs work in ways to sort of target the blood vessels that attack the cancer. They target two proteins. One is VEGF, which you'll hear a lot about, and another protein which we think is important in cancer blood vessel development, that's the protein c-MET. They're what's called MET inhibitors. And there's been interesting activity in prostate cancer with this drug. There's been a very small clinical trial, which we participated in Boston, with this agent in kidney cancer. You will see more information on this drug at the ASCO meeting in June. And the information will probably be public information in May. I think May 16th, ASCO releases all of its results. So you will be able to get your hands on the results from that very small trial in a few weeks, which is good. It's a drug we think has promise, but it does have some side effects that need to be managed. The question, though, one of the fundamental questions, this is important for the cancer advocacy community, kidney cancer advocacy community, will it be tested in kidney cancer? That's still not definite yet. We're pushing them to test this class of drugs, this particular drug and this class of drugs. We're constantly pushing sponsors to do trials, but they're most interested right now in prostate cancer. So when the new trials will start is not entirely clear in kidney cancer. We need to keep pushing them to develop these interesting drugs for our patients. That's a great question. Yes, ma'am.
This is an extension of the questions in regard to how you choose the best patients who have likelihood of responding to IL-2.
Yep.
Does the histology or the pathology, and frankly I don't know the difference between the two, have a major impact? And if so, could you kind of expand on that?
Yes, and no, as I may have gone too quickly about it. We thought the answer was yes. And when it comes to the big differences, clear cell versus non-clear cell, It does, meaning patients with non-clear cell cancer, if they come to us for IL-2, we'll say to them, it's not going to help you, or the chances of it helping you are so small that the potential harm outweighs the help. So to answer one of your questions is for non-clear cell histologies, which essentially is just a medical term for what this thing looks like under the microscope. For non-clear cell histologies, we don't offer IL-2. Whether these new immune therapies work for that class of patients should be tested, and hopefully will be, because there's hope. That's why I mentioned the lung cancer story. If something can work in lung cancer, it might work for these less common kidney cancers. It may work for many other forms of cancer. So that's hopeful. It's a hopeful thing. It's an exciting thing from my point of view. But to take it a step further, while we thought clear cell cancer was more likely to benefit with IL-2, we also thought certain types of clear cell cancer were more likely to benefit. And that's what we tried to prove in the trial, and that's what we couldn't prove. It doesn't mean it's not real, we just couldn't prove it. So we can't improve our selection ability based on looking at the tumor under the microscope in ways that we had hoped. We can do it a little bit, and that's why the response rate went from 14% when the drug was approved to 25% today, but it's not enough. We need to do better so that some patients won't have to go through the side effects if they're not going to benefit from the treatment. Yes, ma'am.
And again, I don't know if I know enough to ask a coherent question here, but this is related. Why would it be that certain tumor types or subtypes would respond better to IL-2 treatment? Is it because of their profile of cell surface markers that would allow the immune system to target them better?
Well, that's actually a very sophisticated question.
Oh.
One that doesn't have a clear answer, okay? It may be, one thing you mentioned may be the answer, meaning it may be that the immune system generally recognizes proteins, usually proteins associated with infections like viruses. So it may be, as you point out, that there are certain tumors that show these proteins to the immune system better than others, and that the immune system could then detect those proteins and say, this is something wrong here, let's go kill it. Okay, so that's one possibility. We tried to prove that in our trial because one of the proteins we looked at was this protein called carbonic anhydrase 9. And we thought this protein was being recognized by the immune system and might predict for benefit. We couldn't prove it. So many people suggested your theory, which is proteins are important. We couldn't prove it in this trial. It doesn't mean there aren't others that are important. We just couldn't confirm it. It also may mean that there's certain aspects of the tumor that even though it's recognized by the immune system, prevent it from dying under the strain of an immune attack. So that has to do with how well a cell dies under stress, a cancer cell dies under stress. So there may be some that don't automatically shut down when they're being surrounded. That's part of it. There also may be, as we talked about another important protein, these proteins that the tumor can make to avoid detection. So sort of the opposite of what you're talking about, that barbed wire analogy that I used. These are proteins that the tumor can turn on and act like barbed wire so that when the cells are coming in, they're turned off. So there's a variety of different theories, and it's probably more than one aspect to this. It's a fairly complicated story.
Thank you very much.
Yeah, great question. Okay, if there are no other questions, we got questions, good.
I wanted to ask back to the CA9, the fact that you expected or you hypothesized that more of that would lead to a greater response to IL-2, you found the opposite to be true?
No, we didn't find the opposite. We found that the folks who had CA9 protein on their tumors did well, or I shouldn't say well, did better than the old numbers. So those patients responded at around 25%. So they did as good as anyone. What was different is the patients who didn't have CA9 on their tumors did just as well.
Okay.
So that's why I said it was bad for the research, but good for those patients, because we would have assumed that if we hadn't done the trial, we would have just said, if you don't have CA9 on your tumor, no IL-2 for you. Yeah. So we did the trial to try to show that. We couldn't. That means, going forward, we shouldn't, we should include those patients getting IL-2.
Well, I'm a complete responder and had, that relatively low level of CA9, so
Right.
I always watched that and wondered,
Yes, you are an
converse.
example of why my research career is floundering.
Sorry.
But that's
Works-
good. I'm
works
very
for
happy
me.
for
It
you,
works
and
for
I'm very happy for those patients on the trial. Right. That's the reason you do the research, is because the CA9 story, and this was scary when I saw it, actually made it into the medical training literature. So if you were an oncology fellow learning about kidney cancer, you learned that, McDermott and others said that CA9 was important, and people with high CA9 should get IL-2. And then when we saw the results of this trial, I was like, oh my gosh, this has become, gospel, and it's not, we maybe not be right. And you're a perfect example of that, and it means we need to do more, we need to do more research in the area. You're an excellent plant. You could not have been a better plant in the audience. Yes, sir.
I touched on it just a little bit. Did you say that you had some non-clear cell people on the MDX 1106 trials?
Not yet. Most of them have been, for the ones where we know what tumors types they had, they've been clear cell tumors. But in some of the future trials, there's small numbers of non-clear cell patients that will be enrolled on those trials. So if there's any sense of activity, that may encourage study sponsors, drug companies to develop it in non-clear cell patients. So they're not going to be excluded on some of the trials going forward. Does that answer your question?
So to your knowledge, there's not any one that's non-clear cell that's had the MDX 1106?
I haven't seen a response in that category, but most of the patients, because the assumption in the field is that clear cell benefits from immune therapies. So when you're trying to prove a principle, they try to collect the patients most likely to benefit, so not to put patients through treatment that aren't going to benefit. But now that we have this proven, or not proven, but now that we have this hint of effectiveness, different types of patients are being included in the trial. So, for example, the trial which combines the MDX agent with Sutent allows non-clear cell patients on it. So hopefully there'll be more of those in the future. And the good news is there's more than one drug company developing these antibodies. And I'll mention that in my talk later this afternoon. There's probably 4 or 5.
But none thus far that has had the drug in them?
As to my knowledge, no. It doesn't mean they haven't been, but I've not seen, because all the work doesn't happen at our place, but I haven't seen a responder who is a non-clear cell. I've seen responders who've had very aggressive tumors, had sarcomatoid features, for example, but I haven't seen one with non-clear cell. That doesn't mean it hasn't occurred.
Thank you.
Sure, good question.